Thank you, sir. Good afternoon, all. So, we have a case of 63-year married female who is a homemaker, resident of Uttarakhand, who is educated up to the Bachelor of Arts, who has a complaint of dry cough with fever with a shortness of breath, MMRC grade 1 for 3 months, for which the patient sought the medical attention in November 2022 and evaluated it in outside hospital, where CT chest, bronchoalveolar lavage along with the lung biopsy was done, and based upon the finding, patient was diagnosed with interstitial lung disease, likely hypersensitivity pneumonitis more than connective tissue disease related, as the autoimmune profile was non-contributory. And the patient was started on the tapering doses of prednisolone and the azathioprine, and following which the symptoms has resolved. Patient again sought the medical attention in December 2024 with a complaint of bilateral periorbital swelling for 2 years, headache for 6 months, and the generalized abdominal pain for 3 months, for which the patient was evaluated in outside hospital. For abdominal pain part, USG wall abdomen was done, which has shown the bilateral hydronephrosis, following which CCT abdomen with a CT urography was done, which has shown supra and the infrarenal pre-aortic cuffing with a bilateral PUG obstruction causing the bilateral moderate hydronephrosis. With a suspicion of the IgG4 related disease, serum IgG4 was done, which was normal, and the screening whole body PET CT was done, which has shown there is a mild pre-vascular aortic thickening was there, along with there is a bilateral hilar lymphadenopathy with a pre-vascular lymphadenopathy was there, along with a bilateral PUG obstruction with a mild to moderate pericardial effusion was there. And patient was diagnosed as IgG4 related disease, and the treatment of the prednisolone and the azathioprine was continued. Despite the medication, her symptoms has not improved, and the patient has visited the AIIMS medicine OPD in January 2025. With a detailed history, so patient has observed the periorbital swelling in 2022, which has a waxing and the waning course, not associated with pain, ulcer, pedal edema, or abdominal distension, or without any diurnal variation. Patient also has a complaint of the headache for 6 months, which is a holoperennial, episodic, dull aching, mild intensity without interfering daily activity, not associated with nausea, vomiting, visual change, eye redness, and the nasal congestion. Patient also has a generalized abdominal pain, which is insidious onset, gradually progressive, diffuse, dull aching with the intermittent in nature, without any aggravating or relieving factor. There is a no associated with nausea, vomiting, altered bowel habits. There is a no history of fever, loss of appetite, and the loss of weight. There is a no history of the cough with expectoration, hemoptysis, shortness of breath, passage of polar urine, burning micturition, phlegm, pain, or frothy urine. No history suggestive of connective tissue disorder, no history of chest pain, palpitation, syncope, bleeding from any side, seizure, or focal neurological deficit. While the past history and the personal history is non-contributory, no history of similar illness in the family members, while the patient is married with a past history of 2 pregnancy with 2 live birth, and the menopause achieved at the age of 48 years. While in examination, patient is oriented to time, place, and person with a normal vital, while head-to-toe examination is a normal, except for that there is a bilateral, multiple lesions are present in the periorbital region, which are present in the both eyelid, yellow-orange color with ill-defined margin with raised surface, which are extending up to cheek, not associated with pain, ulcer, or localized tenderness. And based upon that, it is a lesion, xanthelisma-like lesion was there. While in systemic examination, all systems are normal except there is a bilateral basal 5 preparation was present. So, based upon the history, physical examination, and the previous medical record, we have the differential diagnosis of IgG4 related disease, histiocytic disorder, and the secondary retroperitoneal fibrosis due to a lymphoproliferative disorder, autoimmune disorder, disseminated granulomatous disorder, and then it could be due to a drug induce. So, first IgG4 related disease. Points in favor are there is a soft tissue thickening in the anterior part of aorta. There is a bilateral PUJ obstruction causing the bilateral hydronephrosis. Along with there is a pericardial effusion and no bony lesion. Points in against are there is a no response to steroid. no middle or distal ureter involvement with a normal IgG. Our second differential is histiocytic disorder. Points in favor are there is a bilateral periorbital xanthelasma like lesion was there. There is a proximal ureter involvement in form of the PUJ obstruction. There is a pericardial effusion and the periaortic involvement is present in both in suprarenal and the infrarenal compartment. Points against are there is a no sclerotic or lytic lesion in the bone and there is a no renal involvement. Our third differential is a secondary retroperitoneal fibrosis. Points in favor are there is a bilateral hilar lymphadenopathy and there is a pericardial effusion. Points against are there is a no B symptom, there is a no history suggestive of connective tissue disorder, there is a no history of drug causing the retroperitoneal fibrosis, and the patient has a bilateral and the symmetric pattern of retroperitoneal fibrosis, while secondary retroperitoneal fibrosis causes a unilateral asymmetric pattern of retroperitoneal fibrosis. So, keeping this differential in mind, we have further evaluated the patient. On evaluation, there is a dimorphic anemia due to iron deficiency anemia along with a vitamin B12 deficiency. There is a hypoproteinemia. Viral marker were non-reactive. Inflammatory marker were raised. Lipid profile is normal despite having xanthelasma-like lesion, and the thyroid profile is also normal. While in etiological workup, serum IgG and the IgG4 level are normal. Peripheral blood flow cytometry along with the light chain disease workup were non-contributory. Workup for a granulomatous disease including urine histoplasma antigen and the sarcoidosis workup were non-contributory and the autoimmune profile were negative. While patient also has a left bundle branch block in ECG along with echo was showing the moderate pericardial effusion with ejection fraction of 50 to 55%. So, during the hospital course, patient headache intensity and the frequency started to get worsen with one episode of vomiting, for which the fundoscopy was done, which has shown the papilledema and the neuroimaging was done. Now, I would like to call Dr. Srikruti for discussing the neuroimaging. Yes.
Good afternoon, everyone. I will be presenting the radiological findings of the case. So, we have a single endpoint MRI, brain and orbit of January 2025 and the NCCT head. So, on the NCCT, we can see subdural hypodensity and thickening on the right side and minimally also on the left side along the frontal lobes. And in the flare and T2, there is isointense pachymeningeal thickening, and on the T1, it appears isointense to the cream matter. On the diffusion in EDC, there is no restricted diffusion, no SWH looming foci to suggest hemorrhage, and T1 post-cat, there is homogeneous enhancement. These are the coronal sections where we can see there is a pachymeningeal enhancement causing compression of the underlying grading parenchyma. There is midline shift to the left. These are axial orbital sections. In the bilateral periorbital region, soft tissue lesions are present. This is the T1 non-fat saturated image, and here is the hypointense lesions, which are then enhancing in the post-cat images. These are the thin orbital coronal sections. So, in the right intracoronal space, here we can see this is the right optic nerve, and this is the inferior rectus. In between, there is this soft tissue intensity. And on fat side also, it appears isointense to the muscle. And here is the sagittal oblique of the right orbit, where we can see the lesion is just inferior to the optic nerve shape. So, based on our findings, there is a pachymeningeal nodular thickening and enhancement, and right orbital intracoronal lesion, and bilateral periorbital lesions, soft tissue lesions are differential with the IgG4 disease, lymphoma, sarcoidosis, and Erdheim-Chester disease.
Thank you, Dr. Srikruti. So, in view of the raised ICP as discussed by Dr. Srikruti in neuroimaging, anti-edema measures were taken and the patient also was started on the dexamethasone as there is a pachymeningeal thickening was there. Along with there is a neurosurgery review was also obtained and the patient was planned for craniectomy with a diagnostic pachymeningeal biopsy. Meanwhile, a whole body PET CT was done. Now, I would like to call Dr. Anushna for discussing the PET-CT finding of the patient.
Good afternoon, everyone. I'll be discussing the FDG PET-CT of this patient done on 30th January 2025. This is the maximum intensity projection image of FDG PET. Here we can see normal physiological uptake in brain, myocardium, excretory activity in kidney and bladder, as well as extravasated injections at the injection site. Also seen abnormal increased FDG uptake in the bilateral frontal region in the mediastinum, as well as in the distal half of bilateral femora, bilateral tibia, and distal half of bilateral femur. These are the transaxial sections of CT and fused PET-CT images. Here we can see FDG-avid meningeal thickening, which is causing midline shift towards left. Also seen FDG-avid soft tissue thickening lateral to the zygomatic process of bilateral frontal bones. Here we can see FDG-avid soft tissue thickening around the arch of aorta, as well as pericardial effusion, and FDG-avid soft tissue thickening noted anterior to the Sylvius sternum. In this image, here we can see there is actually perinephral fat expanding, which is more prominently seen on the left side upper bone, and FDG-avid thickening also noted in these neural foramina as well as sacral canal. FDG-avid cortical thickening as well as intramedullary sclerosis also noted in the bone. These are the transaxial sections of the distal bilateral femur. So from the above findings, the differentials include non-Langerhans histiocytosis like Erdheim-Chester disease, IgG4 related disease, or retroperitoneal fibrosis, sarcoidosis, and lymphoma. Both sarcoidosis and lymphoma can involve CNS, and it can also present as soft tissue lesions as this, but the skeletal involvement, this sclerotic lesions which are against sarcoidosis and lymphoma. The finding against retroperitoneal fibrosis are sparing of IDC and sparing of the ureters. The typical findings like hairy kidney sign and coated aorta sign are more in favor of Erdheim-Chester disease. Thank you.
Thank you, Dr. Anushna. So, we have a patient with this PET finding. For raised ICP, anti-edema measure was taken, and following the headache has subsided, and the pachymeningeal biopsy was also deferred. As a PET-CT was showing the periorbital skin lesion with the FDG avid lesion for which the skin biopsy was done. Now, I would like to call Dr. Vijay Nirmala for discussing the histopathological finding of the periorbital skin lesion.
Good afternoon, everyone. Coming to the histopathology part, we received a biopsy from periorbital lesion. We can see here there is thinning of the epidermis and infiltration of the upper to mid dermis by sheets of these clear cells. On going to high power, we can see these clear cells are the lipid-laden histiocytes, and these are the two-tone giant cells, where we can see a ring of nuclei which is surrounding a homogeneous eosinophilic material and surrounded by a foamy cytoplasm. So based on this morphology, we had a differential of xanthogranuloma and Erdheim-Chester disease. So we performed a histiocytic marker, which was CD163, which was diffusely positive, and other markers like CD1A and Langerin to rule out Langerhans histiocytosis was negative. And on BRAF IHC, which using VE1 clone, these foamy histiocytes were showing diffuse cytoplasmic positivity. So based on these features, along with clinical and radiological findings, we gave a diagnosis of Erdheim-Chester disease.
Thank you, Dr. Vijay Nirmala. So we have a patient, 63-year-old female with a xanthelasma-like lesion with a pachymeningeal thickening in the neuroimaging, with retroperitoneal fibrosis with sclerotic bone lesion in the PET imaging, with foamy histiocyte with a fibrosis in histopathological examination. Patient was diagnosed as Erdheim-Chester disease with BRAF V600E mutation. Now I would like to call Dr. Aji to carry out the further discussion.
Thank you, Dr. K. Good afternoon, everyone. So, going on to histiocytosis. So, these are rare disorders stemming from dendritic or macrophage lineage. Their presentation ranges from mild to life-threatening disease. So, the current classification splits these disorders into 5 groups. So, these are the 5 groups of classification of histiocytosis: the L group, C group, R group, M group, and H group. In this, the L group contains the Langerhans histiocytosis. The Erdheim-Chester disease, due to similar pathophysiology, was integrated into this group in the year 2016, and there are other variants like mixed as well as indeterminate in the L group. So, going on to the Erdheim-Chester disease, this was first described in 1930 and currently has over 1,500 cases reported. In India, the reported cases are less than 10. So there are various mutations described in the past 10 years, and of which BRAF V600E was the first mutation discovered in the year 2010, following which MAPK mutations were discovered in 2012. So what is the pathophysiology? So the first step is the acquisition of BRAF V600E mutation in the hematopoietic stem cells. These cells then go to different organ systems, constitutively activate multiple pathways like the RAS pathway as well as the mTOR pathway, finally resulting in inflammation and fibrosis in various organ systems. So how does it clinically present? So this is a disease which predominantly affects adults, and the mean age of diagnosis is around 55 years. Males predominate with a ratio of 3:1, and diabetes insipidus is the most frequent initial sign, followed by the neurological manifestations. So if we see the clinical domains of involvement, these have specific features in each organ system. So like in retroperitoneum, it causes the hairy kidney. In bones, it has the osteosclerosis around the ears, around the knees, and in cardiac, it forms atrial pseudomyxoma, as well as in arterial system, it causes the porta aorta. In dermatological involvement, like xanthelasma-like lesions. In nervous system, it involves all layers. So if we arrange those domains in the order of incidence, long bone involvement will be the first with a seen in almost 74 to 95%, followed by porta aorta and bone pain. In our patient, majority of these manifestations were present except for a few. Our patient also had rare features like pericardial involvement as well as hydronephrosis. So coming on to the cutaneous involvement, we can see that our patient had xanthelasma-like lesions. So these lesions are present in around 22 to 33% of patients, predominantly on the eyelids or periorbital areas. So neurological involvement is seen in around 25 to 50%. They present with a variety of manifestations depending on the site of involvement. However, in our patient, headache was the only presentation. This CNS involvement is an independent predictor of death. Another point to note here is that patients with CNS involvement are more likely to have xanthelasma as in our patient. So what are the diagnostic modalities used for this patient? So this is a combination of clinical, histopathological as well as molecular diagnosis. Biopsy is mandatory, and histology usually demonstrate foamy histiocytes with fibrosis, and immunophenotyping is used to differentiate this from Langerhans histiocytosis. And imaging features usually show typical features like the osteosclerosis, coated aorta, and other findings. So BRAF and MAPK mutations are diagnostic of this disease. So if we see the radiological findings of this patient, patients in skeletal involvement, almost 96% will have metadiaphyseal sclerosis. In CNS involvement, the most commonly involved organ systems are the pituitary, which will be seen in around 50 to 75%, followed by T2 hyperintensity in supratentorial white matter, followed by orbital involvement as pons, as well as in meningeal involvement. Hairy kidney will be seen in around 68% of cases, and coated aorta will be seen in around 50 to 60% of patients. In our patient, skeletal involvement, retroperitoneal involvement, vascular involvement was there. In the neurological involvement, only rare features like meningeal involvement and orbital involvement was present. There was no pituitary involvement or white matter hyperintensities. So going on to the treatment of the patient, it depends on whether the patient is symptomatic or asymptomatic. In asymptomatic individuals, we usually observe them and do periodic clinical evaluation. If the patient is symptomatic, we decide treatment based on the mutation. So if mutation is present, we go for mutation guided therapy. If there is no mutation, we go for conventional immunosuppressive or cytotoxic therapy. So mutation directed therapy, if BRAF V600E positive mutation we get, we treat the patient with vemurafenib, which has shown excellent results based on trials. And there are some side effects for this drug as well, like alopecia, rash, arthralgia, and rare side effects like QT prolongation as well. So if vemurafenib is not available or not tolerated, we go for alternative options like dabrafenib, MEK inhibitors, PEG interferon alpha, as well as systemic chemotherapy or biological agents. So how do we assess the response to treatment in these patients? So it is predominantly by imaging like FDG PET or CT MRI. So these imaging should be done 2 to 6 months after initiation of a new therapy. Later, once the disease is stabilized, we individualize treatment based on that. With regards to endocrinopathies, these can persist or can develop despite treatment. So annual endocrine evaluation is mandatory in these patients. So when do we stop treatment for such patients is usually therapy is continued indefinitely. However, cessation can be attempted only for stable disease based on a case-by-case basis. So what is the prognosis of the patient? So prior to targeted therapy, the overall survival was around 43%, but after the advent of targeted therapy like vemurafenib, the overall survival has improved to 83%. So further course, the patient was diagnosed based on clinical, radiological and histopathological parameters, and patient after medical oncology opinion was started on tab vemurafenib 480 mg BD, and coming on to the clinical outcomes, patient had clinically her headache, abdominal pain had significantly improved, and 2 months post treatment we can see that there is resolution of her eyelid lesions. Coming on to the treatment response radiologically, this was 2 months after the initiation of treatment. We can see that the meningeal enhancement has decreased in every part of the body. So previously we had seen brain, now we are seeing the aorta. The coating of the aorta has, the FDG uptake has significantly reduced. So coming on to the take home points, Erdheim-Chester disease is a rare systemic histiocytosis with multi-organ involvement. Periorbital xanthelasma like lesions are often the clue to such disorders. Mutation directed therapy is a charged weapon against the disease, and this mutation directed therapy has significantly improved the overall survival rates over the past few years. So we thank all the departments who have helped us in the diagnosis and management of the disease, and we thank all the departments who have come here today. Now I call upon our faculty preceptor, Dr. Amandeep sir, to carry on the discussion.
So thank you, Dr. Reddy. So we brought this case because this is a very rare disorder that is fine, but how does it present? It presented with a xanthelasma like lesion, which we often see in our OPD patients with indicating
a label of it's a hypercholesterolemia like findings. Along with that, the patient was presented with diffuse pain abdomen along with one more headache. So this is a very general complaint which this patient comes to us. Now, suspecting a disorder like Erdheim-Chester with these manifestations in OPD is very less likely. How did we suspect it? Is the patient had various investigations with her since the beginning. She also had a PET scan. She was on steroid therapy, but she was not responding well. So we admitted the patient. Meanwhile, during admission, the patient started to have a raised ICP features, and the neurosurgery was of very clear-cut opinion that there is a very significant midline shift. We go for a neurosurgical intervention. Now, the patient family is like, patient is coming to us, walking, talking very comfortably, and we suddenly says, okay, let's go for a neurosurgical intervention. That came as a shocking for them and for us also. But luckily, then with an anti-edema measures part, the patient headache settled, and that prevented from a brain biopsy to get the diagnosis from skin biopsy. So on the PET as well as on the MRI, it was indicated that there is a lesion which we can take a sample from, and so went ahead with the punch biopsy. And the third is the diagnosis was made very rapidly with the help of the various departments collaborating with each other, whether it's radiology, nuclear medicine, dermatology, and a special thanks to the pathology department running for BRAF mutation to get done as soon as possible. And finally, with the medical oncology department, which guided us a lot in managing this patient, and a significant outcome. The patient just had a vimurafenib associated slightly alopecia and graying of the hair. She is comfortable and fine, and she is following up under Sameer Bakshi sir and Deepan Pushpam sir. And vimurafenib being a targeted therapy, and all of the care is now going toward person-centered care. So the results are up to us, and so luckily we are getting such treatment, and it's just been FDA approved in 2017. So for further comments, I would like to invite Nishikant sir, because initial PET was there, but it was done till mid-thigh level, and then we did the whole body PET in covering the this knee joint as well. In that, there was a pathognomic feature of osteosclerotic lesion. So, sir, short comment.
So this patient basically presented with a PET scan done outside, revealing some of the features that we were able to see in our scan. But with the given clinical differential that they had kept, I think the thing that made us think more along lines of Erdheim-Chester was the bony pattern of uptake we were able to see, especially in the distal femur, the proximal and distal tibial ends. So in the MIP image, my SR showed you the findings. So that was, very pathognomonic. Rather than that, it helped us in rule out other differentials, because this hypertrophic pachymeningitis kind of pattern can be seen very commonly in neurosarcoidosis. It can be seen with neurolymphoma also. It can also be seen in IgG4. So that was not a differentiating feature. The skin lesions also could sometimes have mimicked the other pathologies. We didn't find significant pointers towards sarcoidosis. Lung lesions were not very prominent. Mediastinal lymphadenopathy was not very prominent. Salivary gland uptake was not very high. Why we didn't think of lymphoma was because we didn't see the bone marrow reacting. We didn't see the spleen reacting, which usually you do see in cases of lymphoma. So all in all, putting all the pieces of the puzzle together, it pointed more towards ECD.
So we basically took the scans first to the radiology department, and with the discussion with the ma'am, we suspected that there is a significant lesion which is not looking like something normal, and we need to evaluate that further with the PET as well as on the basis of the MRI. It was more of a diagnosis of histiocytic disorder was given by the radiology department. So, sir, a short comment from the management per se, from Dr. Deepam sir, and then.
The one comment I have to make is that the drug was approved in 2017, but for the last 1 year, it has been available at a cost which our patients can afford. And we have started offering this drug in LCH as well as Erdheim-Chester. In fact, I remember 4 years ago, there was a similar case of LCH, but there I said that couldn't be offered this to our patient. And in our experience, we did not find any difficulty in using this drug. Earlier, there were concerns of cutaneous malignancy, but long-term data has shown that most of the time it is a benign skin.
So with this, there's 30 seconds left, sir, for question.
we say that plasma claims. And so the next time you see a patient with plasma, should you get a PET scan and should you think of Erdheim-Chester? There are two groups. One is that if it is a small lesion only in the upper lip, remember in the case was small around, and if it was large, those are the two clues. Is clinical. And then you think of it clinically, then it's probably a periorbital xanthogranuloma rather than xanthoplasma. Then do a biopsy. Biopsy, xanthoplasma will only show from the histiocytic. But if you have a xanthogranuloma, part of the non-active cell histiocytic is good, then you see proton giant cells, which was what was very good demonstrated. So I think the message is that most xanthoplasmas are clinical. Most xanthoplasmas are not associated with more than 80% of people with xanthoplasma will do a so if it is large, round the orbit and shows proton giant cells on that.
Thank you, sir. I would like to invite Sir.